Okay, it is my pleasure to present Professor Medhat AMER, who is the chairman of the Embryology Department of Cairo University and also the former president of the Andrology Mediterranean Association and of the Egyptian Society of Andrology. He is currently the president of the Egyptian Society of Reproductive Medicine and vice president of the Egyptian Foundation of Reproductive Medicine and Embryology, and chairs since 1995, one of the largest private andrology and ART hospital and satellite clinics in the Middle East, Adam International Hospital. So Professor Amer, there is one thing we have in common. We all studied in Saint-Antoine Hospital in Paris and also at Paris 6 University. So you were in Saint Anthony in the urology and andrology department for 3 years in an extra residency program, and you obtained your andrology and diploma for microsurgical techniques at the University of Paris 6, where you were a consultant of andrology. So Professor Amer, please proceed to your presentation.
Thank you, Dr. Xavier, for your nice introduction. I am starting to chair my session, and this topic was selected by Dr. Nuruddin, and I think it's a very interesting topic because many of my patients are asking me if there is any role of medical treatment before non-obstructive azoospermia. But before replying to this question, as you all know, the pituitary gland, FSH and LH, are the direct stimulation from the hypothalamus by GN or LH. After that, LH will stimulate interstitial cells of Leydig to produce testosterone, and FSH will enhance spermatogenesis on Sertoli cells. Together with testosterone and FSH, they will act on the Sertoli cells. And inhibin will be secreted to feedback inhibit the FSH secretion, together with testosterone, which will do a feedback inhibition of LH secretion and regulate testosterone production. To do that, we need receptors. So there are receptors on Leydig cells that receive the LH, and receptors on the Sertoli cells that receive the FSH. Both androgen has also a receptor on the nuclei of Sertoli cells. FSH and testosterone are both necessary and act synergistically together to regulate the receptors and enhance the response of Sertoli cell to nourish and enhance spermatogenesis. What we know about empirical medical therapy in non-obstructive azoospermia is that it has no effect, because usually if the level of endogenous gonadotropin is usually elevated or normal, and most commonly it is elevated, so testes are under constantly high stimulatory effect. So in non-obstructive azoospermia, the pulse is disrupted, in particular regarding to the amplitude of both FSH and LH. So this is a control. As you can see, LH is high, but in non-obstructive azoospermia, the pulse is low. The same happened for FSH. So the optimal stimulation of Leydig and Sertoli cells may not be achieved in a subset of men with non-obstructive azoospermia, and this will lead to lack of adequate intratesticular testosterone level and downregulation of FSH receptors. And intratesticular testosterone is really critical for spermatogenesis and very important for it. And in this patient, usually we have a type, most of the 60% of them or 70% are hypogonadal, with a testosterone level below 300 nanogram per deciliter. And this will reflect the low intratesticular testosterone output caused by reduction in Leydig cell mass or paradoxically weak stimulation of Leydig cell by exogenous LH or both condition. As you know, long ago, we are administering exogenous gonadotropin to restore spermatogenesis in hypogonadism patients. Consequently, hormonal treatment in men with non-obstructive azoospermia has been pursued with the aim of improving spermatogenesis before surgery, despite this patient may display high FSH and LH. And gonadotropin therapy has been explored as a way to optimize and induce spermatogenesis and thus increase success rate in men with non-obstructive azoospermia. The pharmacological principle is to increase intratesticular testosterone, and this can be done by HCG or any other agent like estrogen receptors modulators or aromatase inhibitors. And Shirashi in 2012 published a very interesting paper, and he showed that Leydig cells respond to high dose of HCG stimulation in hypergonadotrophic condition. And this can lead to restoration of free gonadal levels, and he postulated that it may have a positive impact on spermatogenesis and spermatogonia proliferation. And what we know also from the literature, and that sperm retrieval rate in patients with low versus normal testosterone level, that patients with normal testosterone level had a significantly higher chance of sperm successful retrieval. And this is to show you that all the studies are indicating that normal testosterone is a good thing and good prognostic element in these patients. So all these data together suggest that hormonal treatment may be justified in patients with hypogonadism, with low testosterone. And it has been tested by many authors. I will show you later. So medications that boost testosterone production, especially if you use HCG, can lead to a drop on FSH and LH. And we think that this will send endogenous FSH to normal levels and might increase the expression of previously downregulated FSH receptors. As a consequence, administration of exogenous FSH may help in restoring sexual function in patients who has a reduced level of FSH under HCG therapy. However, it has been demonstrated by other teams that desensitization of sexual cell does not occur. But hormonal responsiveness during FSH treatment is preserved thanks to FSH receptor recycling. So, in consequence, it may be hypothesized that at least there is a subset of non-obstructive azoospermia, those with subnormal testosterone level, in this patient, exogenous gonadotropin, HMG and HCG, or selective estrogen receptor modulators can be tried. Actually, this is an interesting paper that I invite you to read if you are interested in the topic. Croppi and Colpi published in January this year, and he summarized the 9 papers that explored the utility of medical treatment before TESE. 5 of them in patients that didn't have TESE before, and 4 after micro-TESE. We have 2 publications in this series of articles. What you will notice that more of the series, each one has its special protocol of treatment, dosage and regimen and patient selection. So they are not uniform. I will concentrate on the first 2, and this is the earlier one, Eidos et al. In Turkey in 2003. He used FSH 3 times per week in patients with FSH below 8 million international unit, and the patient who exhibited high sperm retrieval were those with focal spermatogenesis arrest and hypospermatogenesis. Maturation arrest didn't benefit, and Sertoli cell didn't benefit from this intervention. However, sperm retrieval was high in the treated group, 64% versus 33% in the untreated group. A second old paper in 2005 by Hussein, and he worked on maturation arrest and hypospermatogenesis, and he has striking results. 64% has sperm in the ejaculate. So this paper stimulated the team of Professor Schlegel, and he has done a study on 600 patients, 348 patients, and the other as control. He found that testosterone level didn't differ between patients with positive retrieval and non-retrieval, and he found that in treated patients, 51% had sperm retrieval while in untreated, 61% untreated. The team of Hussein completed their work and reached 600 patients, and they found that sperm recovery rate was 57 in the treated group, the same as Schlegel in treated and untreated, but in untreated group, in their group, they were 33%. So they use that same treatment, and they have equivocal results. Very strange that they didn't reach the same conclusion. The interesting paper of Shirashi in 2012, he worked on hypergonadotrophic patients, like not the other patient, normogonadotrophic one, and using HCG large doses, he was able to take a drop in FSH, and FSH was taken in 13 patients, and after that he used FSH to patients where there was a drop. Interesting, 6 patients had the sperm retrieval in the patient group, which is about 21%, but 4 of them were in the hypospermatogenesis group. For me, the hypospermatogenesis group from our database, if you do a second trial, you have at least 92% of patients that will have sperm. So I don't think that hypospermatogenesis is a group on which we have to focus our researches. This is a paper that we have done also going in the way of downregulation, and we did it with testosterone injections, and then the patient took FSH, and we found two of the 20 patients with positive sperm retrieval, which is equal 10%, but this was not statistical difference with our control group. So you cannot take our study or the study of Shirashi because these numbers are really low. You need more numbers and a big series to know what is going on if you use this protocol. I think that our paper published in 2019 is the largest series in the world up to date, done on 1,400 patients. And we used various protocols, all combinations that you can imagine, and we didn't prove any significant results between treated and untreated patients. So people may say, why don't you give enhanced testosterone production anyway? Actually, there is lack of effectiveness, strong evidence. As you see, it's a debatable issue. Also, it may be a waste valuable female reproductive time. If the lady is old enough, you cannot spend time on doing things you are not sure about it. Also, it is a waste of resources, but because this type of treatment are expensive, and also it is a potential of harm. Yes, if you give wrong high dose, you may have opposite effects. You may suppress FSH if ECG is used alone and you don't use FSH with it. Also, if you exceed certain level in testosterone, you may have an increase of risk of thromboembolic events in ischemic sequelae. You increase hemoglobin and hematocrit levels. And it's a well-known fact in erythrocytosis following testosterone therapy. Also, there was a side effect reported, excessive unilateral proliferation of spermatogonia in a patient with non-obstructive azoospermia after clomiphene treatment in such a patient. So to conclude, as you see, there are no randomized controlled study has been examining the role of medical therapy versus no treatment and didn't compare drug regimens. And a definite conclusion regarding sperm production after enhancement of endogenous testosterone cannot be drawn due to the lack of well-designed clinical trials. Although the rationale of such approach is theoretically sound, studies in the field have provided conflicting results so that the benefit effect of hormonal optimization is yet to be demonstrated. Overall, limited evidence suggests and justifies that hormonal medical therapy might increase sperm recovery rate and allow the return of sperm in some patients with hypogonadism. But on the other hand, the available evidence, although promising, is insufficient to recommend hormonal therapy as a standard clinical practice to improve sperm retrieval for every patient with non-obstructive azoospermia before surgery. Therefore, the final conclusion, it was stated by AUA and MSERM in their guideline in diagnosis and management published this year, that patients with non-obstructive azoospermia should be informed that limited data supporting the pharmacological intervention prior to surgical intervention. And this was a conditional recommendation that it can change at any time with new evidence. And the evidence was the lowest one was the grade C level. So thank you for giving me the chance to speak about this topic.